So we've had a good morning session. We've heard a lot about the environment. We've heard a lot about vectors. We've heard a lot about mosquitoes. We've heard about non-malarial causes of fever. So we're going to open the next round of oral presentations with Priyanka Suresh, who is a visiting instructor in pediatrics. She's going to talk about chikungunya infection during gestation, impact on pregnancy and neonatal outcomes. Priyanka.
Thank you. Good morning, everyone. My name is Priyanka Suresh. I'm a visiting instructor in the Labo Lab. Today, I'm going to be talking to you about chikungunya infection during gestation and its impact on pregnancy and neonatal outcomes. This is a collaborative project with St. George's University in Grenada. So as you all know, chikungunya is a mosquito-borne alpha virus that belongs to the togavirus family. The word chikungunya means that which bends up, which refers to the destructive and debilitating joint pain that can occur during acute infection. Other symptoms include fever, headache, nausea, vomiting, and rash. Now, chikungunya first emerged in the Americas through the Caribbean in December 2013, where it was first noted in St. Martin. By June 2014, it was reported in Carriacou, which is one of the islands of the tri-island state of Grenada, which is our study site. Just a few months later, in December 2014, the Ministry of Health estimated that 65% of the population in Grenada was infected with chikungunya. So many of us know about Zika and how it can be transmitted in pregnancy and can lead to devastating congenital Zika syndrome. But not many of us know about chikungunya and the impacts it can have. In the outbreak during 2005 to 2006, when chikungunya spread from East Africa to the Indian Ocean islands, it was discovered that chikungunya could, in fact, be transmitted vertically. What we know to date about mother-to-child transmission of chikungunya is that it occurs exclusively in the context of intrapartum maternal viremia and can lead to severe neonatal infections and neonatal encephalopathy. The rate of mother-to-child transmission during pregnancy is overall 2.5%. However, this can increase to 50% when the mother is viremic during delivery, with a case fatality rate of 2 to 5%. Common neonatal symptoms of infection include fever, pain, suckling difficulties, rash, and distal limb edema. Now, Patrick Girardin and his colleagues in La Réunion conducted a study where they followed children at 2 years of age from the outbreak, and they found some startling effects on neurodevelopment, with 51% of the children having delays in language and coordination. They then went on to follow these children at 10 years and found, again, significant neurodevelopmental deficits and requirement for physio and occupational therapy. So we were particularly interested to find out if chikungunya could be transmitted in other trimesters of pregnancy, and we also wanted to follow up on the findings from La Réunion. So we had a study funded by Fogarty with the following aims. Firstly, we wanted to determine the prevalence of mother-to-child transmission of chikungunya in Grenadian pregnant mothers, and we wanted to measure the neurodevelopment in their children at 2 years of age. So this study is still ongoing, and we're hoping to enroll about 1,000 mothers and their children who were born during the outbreak, and now we're approximately 2 years after the outbreak. The mothers are completing questionnaires on other biopsychosocial factors that can also impact neurodevelopment, and we're measuring neurodevelopment using the INTER-NDA, which is a global neurodevelopmental assessment tool by Oxford University. We are confirming prior chikungunya exposure using IgG ELISA, and then the main aim is to compare the neurodevelopment in children born to mothers who were exposed to chikungunya during pregnancy and those who were not exposed to chikungunya during their pregnancy. And again, today I'm presenting on the interim findings on pregnancy and birth outcomes. So we have 421 mother-infant pairs to report on today. And we found that chikungunya exposure was more likely in women with lower education levels, but there was no difference in exposure by income, parish, or race. When we compared the mothers exposed during pregnancy to those who were not exposed during pregnancy, there was no difference in hospitalization rates, mode of delivery, gestational age at birth, labor duration, or symptom duration. Our overall IgG results show that the majority of the mothers in our study had prior exposure to chikungunya, 82%, with only 3% of children being IgG positive. So we classified our cohort into two groups. The exposed group was defined as mothers who were IgG positive, and they were also reported infection during pregnancy. And the unexposed group were mothers who were either IgG negative or they were not or did not report infection during pregnancy. Now, unfortunately, a large proportion of our cohort had to be excluded for this preliminary analysis. 112 mothers were not able to recall the trimester of infection. 3 mothers were not able to recall if they were infected during pregnancy, and 1 mother recalled disease, but she was not IgG positive. So as you can see, we had a well-balanced group with mothers infected in their first, second, and third trimesters, but unfortunately, only 1 mother reported infection during delivery, which is, of course, the high-risk group. The overall prevalence of infant infection was similar amongst both groups at about 4%. Now, when we compared the symptoms of chikungunya during pregnancy to the symptoms of chikungunya exposed outside of pregnancy, you can see that the symptoms are similar. There's no difference, with rash, fever, and joint pain being the most common symptoms, which is what you would expect. It does seem that the pregnant women were slightly more symptomatic, experiencing more vomiting, muscle pains, and joint pains. However, it's difficult to differentiate what is due to pregnancy and what can be due to a chikungunya infection. When we look at the individual trimesters, again, there was no difference in the symptoms reported. We then looked at merged categories of pregnancy and birth complications, and we found that there were more afterbirth problems in the mothers who were infected during pregnancy. So when we look at these specific outcomes, we can see that those exposed in the first trimester, there were some trends in the mothers, but there was rash that was a significant problem in the infants. Those exposed in the second trimester, we found that bronchitis was a significant afterbirth problem. And for those exposed in the third trimester, we noticed that hypoglycemia in the mothers and fever in the infants was significant. We found that mothers who were exposed to chikungunya during gestation were no more likely to deliver preterm babies than those who were not exposed. And when we look at growth outcomes, there was no difference in the height of these children, again at 2 years of age. However, the children who were exposed to chikungunya were slightly heavier. Now, our study does have some limitations. It is still ongoing, and this is a very crude analysis I'm presenting to you today. It's a small study size for a rare phenomenon. We only had 1 mother who delivered during delivery, who was infected during delivery, which is of course the highest risk for transmission. Our main outcome, which is the neurodevelopmental assessment, has not yet been evaluated. And of course, there's a potential for recall bias in our questionnaire data. And as I mentioned before, some of our population had to be excluded, which could potentially lead to a misclassification bias. So in conclusion, this study adds to the limited data on the effects of chikungunya during pregnancy and birth outcomes, which can better inform physicians who are dealing with pregnant women infected with chikungunya. There was no difference in child infection rates in mothers exposed and those unexposed. Pregnant women had similar symptoms, but were more symptomatic than non-pregnant women. There was a trend towards more afterbirth complications in the CHIKV gestationally exposed group, and many complications tended to be higher in the exposed group, such as rash, bronchitis in the second trimester, and hypoglycemia in the mother and fever in the infant in the third trimester. And there were no difference in gestational age. I would just like to thank Desiree Lebeau, my PI and mentor, and our team at Grenada, and our collaborators in Oxford University, the study participants, of course, and our funder, NIH Fogarty. Thank you.
Thank you. Questions for Priyanka?
You may have said this, and I may have missed it, but did you look at, since a lot of women are asymptomatically infected with CHIK, did you look at asymptomatic infection? That's one question. And the second question, did you look at Zika co-infection?
So that's a good question. And I think my PI, Desiree Lebeau, is buzzing to give you an explanation on that there.
So as far as Zika goes, Zika hadn't come yet to the island when CHIK was there. So the Zika outbreak was, CHIK was 2014. The Zika outbreak was actually 2016. So Zika had not yet emerged on the island. So we don't have to worry about co-infections. But these mothers have been tested for CHIK and Zika and dengue. And then as far as, what was your first question, Michelle? Oh, so chikungunya is unlike the flaviviruses. Most people believe that most chikungunya infections are symptomatic. So the old rates were that about 90% of people had symptoms when they had CHIK. Now rates are starting to change a little bit, and people are bringing it down to maybe 60, especially with the strain that's now in this America. But yes, we can look at asymptomatic infections because we're testing and they're lab-confirmed cases. So it could be that mothers didn't report symptoms, but then are positive. But the issue is then we have to exclude them because we don't know when in pregnancy they actually got infected. So they're in the excluded group, unfortunately. But we would detect them by lab.
Thank you. You talked about some sources of bias. I was just wondering, is there any blinding in terms of knowing which population was positive for CHIK and which population, what the assessment of the babies were? So is this blinded at all?
No, this is purely based on questionnaire data, and we're following the mothers 2 years after, so they're reporting on the symptoms and what they can remember from pregnancy. Thank you for that.
Thank you very much, Priyanka.
Thank you.